Thank you for standing by, and welcome to Celldex's Phase 2 PN Data Call. Currently, all participants are in a listen-only mode. After the speaker's presentation, there will be a question-and-answer session. To ask a question during the session, you will need to press star 11 on your telephone. To remove yourself from the queue, you may press star 11 again. I would now like to hand the call over to Sarah Cavanaugh with Celldex. Please go ahead.
Thank you. Good afternoon, and thank you for joining us to discuss the results from our Phase 2 Barzolvolimab study in Prurigo Nodularis, or PN. Joining me in the call today are Anthony Marucci, Co-founder, President, and Chief Executive Officer, Dr. Tibor Keler, Co-founder, Executive Vice President, and Chief Scientific Officer, Dr. Diane Young, Senior Vice President and Chief Medical Officer, and Terry Lauber, Senior Vice President and Chief Commercial Officer. Please note the slides for today's call are available on the Investor Relations section of the website. Before we begin our discussion, I'd like to direct your attention to Slide 2 with respect to information regarding the forward-looking statements that today's speakers will be making. Please be advised that a question-and-answer period will be held later in this call. I'd now like to turn the call over to Anthony on Slide 3.
Thank you, Sarah, and good afternoon, everyone. Thank you for joining us. Today we are reporting Barzol's results from our fourth indication, a Phase 2 study in Prurigo Nodularis, or PN. PN is a chronic itch-driven skin condition with a highly symptomatic patient population. At Celldex, we are leading important science in the exploration of mast cell biology with the goal of delivering life-changing therapies for patients with allergic, inflammatory, and autoimmune diseases. We have repeatedly demonstrated Barzol's ability to profoundly deplete mast cells in best-in-disease data observed in 3 indications to date: chronic spontaneous urticaria, symptomatic dermographism, and cold urticaria. All of these showed unequivocal Phase 2 data and progressed quickly to Phase 3 development. Our interest in understanding if mast cell depletion can provide clinical relief for patients with serious diseases and data from our Phase 1 proof-of-concept study in PN supported the initiation of the Phase 2 study. We are disappointed to share that the trial did not meet the primary or secondary endpoints. Results from this study clearly showed profound systemic depletion of mast cells as evidenced by the reduction in serum tryptase. But unlike our intravenous Phase 1 study, this Phase 2 sub-Q study did not result in improvements in itch or skin lesions for patients, indicating that mast cells may not be the key pathogenic driver of symptoms in PN. Because of this outcome, we are discontinuing the Phase 2 trial in PN and will direct our resources to the remainder of our present and future portfolio. We remain focused on driving mast cell category creation and delivering on Barzolvolimab's promise for patients, particularly in our 3 ongoing Phase 3 urticaria studies, which we expect to share top-line data in the September-October timeframe. Before I turn the call over to Diane to walk you through the data, I'd like to extend our gratitude to all the patients, investigators, and site staff around the world who participated in this trial and supported the advancement of mast cell science. Diane will walk you through the results we have to date, and at the end of the call tonight, we will answer as many questions as we can. As a reminder, this is a top-line analysis with additional work still to be done. I will now hand the call over to Diane.
Thank you, Anthony. Before we review the data, let's spend a little time discussing this difficult-to-treat indication. Prurigo nodularis is a chronic inflammatory disease. Patients are often covered with hard, itchy skin lesions. The intense itching causes scratching to the point of bleeding and pain, and the scratching in turn can cause more skin lesions, perpetuating the disease cycle. PN is further complicated because it is often associated with a range of systemic comorbidities, including chronic kidney disease, metabolic disorders, HIV and tuberculosis infections, hepatic disorders, and autoimmune diseases. Patients with PN have also been shown to have increased rates of multiple cardiovascular comorbidities, including heart failure. Not surprisingly, given the relentless itching, patients frequently also exhibit psychiatric comorbidities such as depression, anxiety, and obsessive compulsive disorder, further complicating management. While there has been progress in this space with the introduction of recently approved biologic therapies for prurigo nodularis, there is still a significant unmet need. As we explored the science of chronic itch, it became increasingly clear that investigating a mast cell depleting agent was warranted in prurigo nodularis. Evidence indicated that mast cell interaction with sensory neurons is involved in the amplification of chronic itch and neuroinflammation, and could play an important role in this scratch-itch cycle. Additionally, studies have shown that mast cell numbers are increased in PN lesions. We conducted a small 23-patient phase 1b study with intravenous barzolvolimab and saw positive results across both itch reduction and nodule resolution at the highest dose tested, and that merited additional exploration in a robust phase 2 study. Turning to slide 4, I will first walk you through the phase 2 study design. This was a randomized, double-blind, placebo-controlled parallel group study that evaluated the efficacy and safety profile of 2 dose levels of barzolvolimab administered subcutaneously compared to placebo in patients with moderate to severe PN who had inadequate response to prescription topical medications or for whom topical medications were medically inadvisable. 140 participants from 6 countries and 48 sites were randomly assigned on a 1:1:1 ratio to receive placebo or barzolvolimab injections of either 150 milligrams or 300 milligrams every 4 weeks after an initial loading dose of 450 milligrams during a 24-week treatment phase. Participants then entered a follow-up phase with no treatment for an additional 16 weeks through week 40, with an option to enter an open-label extension. The primary objective of this study was to evaluate the clinical effect of barzolvolimab compared to placebo on itch response as measured by the proportion of participants with greater than 4-point improvement in the worst itch numeric rating scale at 12 weeks. Key secondary objectives include itch response compared to placebo at different time points, the assessment of skin lesions as measured by the Investigator Global Assessment, and safety. The primary analysis was conducted after all patients had completed the 24-week placebo-controlled treatment period. On slide 5, you will see a table of baseline characteristics for this highly symptomatic patient population. Demographics and baseline disease characteristics were generally well balanced across treatment groups and consistent with other clinical studies in PN. As expected in this indication, patients on study tended to be older and had highly symptomatic moderate to severe disease. The next slide, slide 6, shows the results for the primary endpoint, the percentage of patients who had greater than 4-point improvement in their worst itch numeric rating scale. The worst itch numeric rating scale is a single-item patient-reported questionnaire that measures itch intensity over the previous 24 hours. The scale ranges from 0, indicating no itch, to 10, indicating worst itch imaginable, and patients in this trial at baseline had a mean worst itch NRS score of greater than 8. As you can see here, patients treated with barzolvolimab did not have differentiated responses compared to placebo across either dose or at any of the time points. Similarly, on slide 7, we show key secondary endpoints, including the Investigator Global Assessment for Chronic Nodular Prurigo Stage, which is a 5-point clinical scale that dermatologists use to measure the severity of prurigo nodularis. It evaluates the number and appearance of palpable skin nodules to gauge disease severity. There is also a secondary endpoint that looks at both worst itch and Investigator Global Assessment combined. Across these endpoints, barzolvolimab did not demonstrate differentiation compared to placebo. Based on these outcomes, we are in the process of discontinuing the phase 2 study in prurigo nodularis. We just received these data, and we have more work to do to understand the discrepancy between our phase 1b and phase 2 studies in this indication. While the patient characteristics across the two studies were similar, the phase 2 study certainly included a much larger sample size. The route of drug administration was also different, from IV in the phase 1b to sub-Q in the phase 2. IV administration is associated with more rapid and higher drug concentrations relative to sub-Q. We can't rule out that these differences may have contributed to the difference in outcome. However, both studies achieved profound decreases in circulating tryptase. We have biopsy samples that may give us better insight. We will analyze the biopsies from this study in the coming months, as we believe this information will increase our learnings. Our current assessment of the available data suggests that mast cells may not be a key pathogenic driver of symptoms in prurigo nodularis, and at this time, we are not planning to move forward with further development in PN. If new data or new science changes our thinking, we are open to exploring this question in the future, if it makes sense. For now, we are focusing on indications of higher priority. While we are disappointed that this study did not confirm the promising signal we saw in our phase 1b study, we are really pleased with these new data that further support the favorable safety profile we have observed to date with Barzolvolimab. The 450 milligram loading dose, followed by the 300 milligram Q4-week dosing regimen, achieves the highest subcutaneous exposure studied to date. Slide 8 provides a summary of the top-line safety data. Overall, Barzolvolimab was well tolerated. We are very pleased with the safety profile demonstrated in this phase 2 study, which remains entirely consistent with our prior studies at these dose levels and in an older patient population with high comorbidity burden. As noted on the slide, there was a single serious adverse event reported by an investigator as treatment-related and described as aseptic meningitis. We strongly disagree with the investigator's assessment, and our conclusion was also supported by the Independent Data Monitoring Committee. The clinical symptomatology does not support the investigator's assessment. There were no typical clinical signs suggestive of this diagnosis, such as headache, neck pain, or fever. This 65-year-old female patient had a primary complaint of chest pain and weakness, which began 3 weeks after completing her Barzolvolimab treatment. She had an extensive workup over a 4-week period, which ruled out cardiac, pulmonary, and GI causes, and subsequently neurologic diagnoses were considered. Her cerebrospinal fluid showed mild lymphocytic infiltration with normal protein and glucose, which is not typical with meningitis. Steroids, antiviral therapy, and antibiotics were administered, and the patient made a full recovery. We believe the time course, lack of symptoms, and spinal fluid findings suggest this is more consistent with neuroinflammation related to a viral infection and is not related to study drug. 11 patients, including 2 patients on placebo, discontinued treatment due to an adverse event, 5 considered related to treatment, and 6 considered unrelated. Urticaria, related, and worsening prurigo, unrelated, occurred in 2 patients each. The other events occurred in single patients and were in line with what has been seen in prior studies, with one exception. 1 death, cardiac failure, which was assessed as not related to treatment by the investigator sponsor and the Data Monitoring Committee, was reported on study. This was in a 73-year-old man with multiple concomitant cardiac risk factors at baseline, including diabetes, hypertension, obesity, coronary artery disease, heart failure, COPD, and low baseline oxygen saturation. As a reminder, the PN population is an older population with high comorbidity burden, and as such, it is not uncommon to see serious adverse events that are not related to treatment. When we look across the totality of the safety data in the study, we see a safety profile that is very much consistent with our other studies. Looking to the bottom of the table, the most frequently reported adverse events observed in more than 10% of participants in any treatment group were hair color changes and nasopharyngitis, all of which were grade 1 and grade 2. Overall, we are encouraged by the consistent safety profile we have seen with barzolvolimab in this trial, where we explored the loading dose and 4-week dosing regimens. These data give us continued confidence in the overall safety profile, and particularly in the ongoing phase 3 studies in CSU, cold U, and symptomatic dermographism, which also include the loading dose. I will now hand the call back to Anthony, who will wrap things up. Anthony?
Thank you, Diane. Turning to slide 9, while we are disappointed that the study did not confirm the promising signal that we observed in the phase 1b, we are proud of our progress and continued execution. As leaders in mast cell biology, we are committed to delivering life-changing therapy to patients in need. The learnings from this study are important for the future of the Celldex pipeline across not only barzolvolimab, but also CDX-622 and additional candidates in development. The new data presented today continue to build barzolvolimab's highly differentiated profile. While expected, it was reassuring to see that the loading dose combined with 4-week dosing demonstrated a favorable safety profile consistent with our prior studies and drove rapid declines in tryptase, which positions us well for our ongoing phase 3 studies. In closing, barzolvolimab has significant potential to become a transformational medicine for patients, and we are focused on driving mast cell category creation and delivering on barzolvolimab's promise, executing on ongoing trials, and continuing to explore diseases of high unmet need where barzolvolimab could play a role. We look forward to sharing additional important information about barzolvolimab in the coming months. We expect we will be in a position to report data in both the EMBARK CSU phase 3 studies in the September-October timeframe. As previously shared, we anticipate a readout of the phase 2 data in AD late fourth quarter. And in addition, we look forward to sharing more about our broad life cycle development plans for Barzol later this year as well. We appreciate your support and look forward to answering your questions tonight. As a reminder, these are top-line results, and we are still reviewing the data. We will do our best to answer your questions, but may need to follow up at some point. Operator?
Thank you. As a reminder, to ask a question, you will need to press star 11 on your telephone. To remove yourself from the queue, you may press star 11 again. We ask that you please limit yourself to one question and one follow-up to allow everyone the opportunity to participate. Please stand by while we compile the Q&A roster. Our first question comes from the line of Thomas Smith of Leerink Partners. Your line is open, Thomas.
Hey guys, good afternoon. Thanks for the updates here and thanks for taking our questions. A couple if I could. Just first on safety, I was wondering if you could provide a little more color on the clinical course for the aseptic meningitis case. Was there any neutropenia observed with this patient? Were there any other confounding factors? It sounds like the patient made a complete recovery, which is good, but any other findings you can add from the data monitoring committee review for this patient?
Sure, Tom. Diane?
Yeah. So, as I said, we don't agree with the investigator on the diagnosis of the causality. As I described, the patient did not have any symptoms consistent with that diagnosis. They did have an extensive workup, as I outlined in the description, and ruled out many different other causes. We think that the clinical picture of the chest pain, which really went on for weeks, and as well as the modest increased cells in the CSF, really indicates some sort of neuroinflammatory process, most likely, due to a virus. And they did not have any neutropenia. The patient had absolutely no neutropenia throughout the course.
Got it. That's helpful. And as a follow-up, can you just comment directly, were there any hypersensitivity or anaphylaxis events observed in this study? And then just maybe as a last question, could you just remind us from the phase 3 CSU program, the timing and outcome of your latest data safety monitoring board committee and any potential read-throughs from this PN study to the CSU program. Thanks so much.
So in terms of hypersensitivity, there were no cases of anaphylaxis in the study. There were 2 patients who discontinued treatment for urticaria. One was grade 3, one was grade 2. They responded to medications. In terms of the phase 3 CSU, we're having regular meetings for the Data Safety Monitoring Committee. There's nothing particularly there. We do not believe that there is a read-through from these results today to that. Those studies are really supported by very robust phase 2 studies, both in CSU and in CIndU. And I would say from the standpoint of this study, so we have no concerns about efficacy. We feel, if anything, that this study, the safety profile really looked great, even with using the higher dose. And we feel that reads through well to all of our indications.
Super helpful. Thank you, guys. Appreciate the updates.
Thank you. Our next question comes from the line of Yaron Werber of TD Cowen. Your line is open, Yaron.
Great. Thank you so much. I also had a question on, in terms of some of the read-throughs maybe to atopic dermatitis, I know obviously each condition is very different from the other, but maybe just remind us the biological support for running the AD study. And then secondly, just on the CSU studies, can you give us maybe a little bit of a sense on the DSMB side, kind of like what are they looking for in terms of, we get a lot of questions as to what are elements that DSMB is looking for that would drive potentially changing the study in any way. I know you obviously enrolled extremely quickly and 6 months ahead of schedule. Thank you.
In terms of the DMC, there's really nothing particular. They have a charter. They review all the safety in an unblinded fashion on an ongoing basis and advise us on things that we need to do with the study. But there is nothing particular.
And we also have the adjudication committee.
Yeah. Adjudication committee.
So all that's in place year-round. And it's been pretty consistent since we started the program in phase 1, and nothing's changed.
So to your first question, Yaron, regarding the read-through to atopic dermatitis and our rationale there, certainly those indications share some of the components of the pruritic disease, and that was the basis for some of our rationale to move into atopic dermatitis after we had the phase 1b data in PN. However, they are different patient populations. Mast cells are known to contribute to other parts of the inflammatory process in atopic dermatitis, and we certainly plan on completing the atopic dermatitis study and look forward to the readouts and the learnings from that study, as we do appreciate that it's a different indication, despite that they do share components of the role of mast cells in driving the pruritic itch part.
Yaron, do you have another question?
No, that's perfect. Thank you.
Thank you. Our next question comes from the line of Iris Gao of Guggenheim. Please go ahead, Iris.
Yeah. Hi, everyone. Thanks for taking my question. Mine would also be on safety. I wonder if you can give more colors on the frequency of neutropenia and skin hypopigmentation from this study, and specifically in the 150 milligram group, and also how soon was onset and stuff like that. Thank you.
So as I said, we're very pleased with the safety data in this study. We had a low incidence of neutropenia, so it was below the 10% threshold that we are showing in the table. All the neutropenias were grade 1 and grade 2. There was no association with infection, and there was one discontinuation for neutropenia, which was grade 2.
As far as the hypopigmentation, there were 2 cases, one on placebo and one on drug.
Yeah, thank you. If there's any more color on the onset of the skin hypopigmentation, do you know how long it took for them to show up?
The skin hypopigmentation occurred for the Barzolvolimab patient occurred at about the 6-month time point.
Thank you very much. Appreciate it.
Thank you. Our next question comes from the line of Kristen Kluska of Cantor. Your line is open, Kristen.
Hi, everyone. Thanks for taking the questions. First, I wanted to ask if any of the patients presented with comorbidities where you were able, in a non-direct measurement way, able to see any effects. And then second, recognizing you're still digesting this data, I'm wondering if you're thinking about any thesis where this could be a potential candidate to further look at with a bispecific in the future, especially considering there is a type 2 inflammation component to PN.
So I can answer, we're going to, look at questions like comorbidities and do we have any anecdotal evidence, in the study as we do in all our programs. It's a little difficult because in the inclusion-exclusion criteria, you tend to want people that are fairly well controlled for their other comorbidities, but we will look, and I will let Tibor answer the question about bispecific.
Sure. Certainly, we look at all the learnings that we get from our studies with Barzolvolimab as helping us understand the role of mast cells and how that affects our pipeline development. So, Kristen, we obviously consider the option, the possibilities of bispecifics in the future, and that's something that as we dig through this data deeper, once we have all of that data in-house, we will look into very carefully.
Yeah. And Kristen, we're also looking at biopsies that we've taken on study. We'll be analyzing those and comparing them to the phase 1b biopsies, since that was IV and this was sub-Q, see what we can learn from that analysis as well. So there's a lot of stuff we still need to do. I mean, we just got these data in a few days ago, but certainly as we learn more, we'll communicate that out to everybody.
Thank you. Our next question comes from the line of Sam Stutsky of LifeSci Capital. Your line is open, Sam.
Hi, this is Oliver McCammon on for Sam Slutsky. Thanks for taking my questions. So first one for me is just, as you think about mast cell biology post the urticaria, PN, and EoE randomized readouts, how are you thinking about indication expansion going forward, and generally the speed of the indication expansion for Barzolvolimab and CDX-622? And then I have one follow-up as well.
Yeah, so we'll discuss more about where we're going in 2027 with Barzol later on this year. There are several indications that we're looking at, and we would imagine starting those studies up sometime in the first half of 26 or early second half of 26. Certainly, as we go through our criteria, it hasn't changed. We look at unmet need, we look at epidemiology, we look at the markets, we look at the ability to do studies and the probabilities of that. So that hasn't changed. But I think as we look through and as we learn more, we'll have more information to share with you. But I think that we go through a pretty rigorous process. And certainly also we're trying to learn, we know mast cells are implicated, but what we're learning is that especially in EoE and then now PN, on the sub-Q formulations, that does not meet our hurt rates, and it certainly doesn't have a big impact. So we're looking to learn, and we're looking to go back and take those learnings and move forward into new indications. So we'll update you on where we're going later on this year on that.
Got it. Thank you. And then curious on why the aseptic meningitis patient received the lumbar puncture, basically trying to get a sense of maybe whether/why they were worked up for this. Thanks.
So as I said, the workup went on over many weeks. There were several hospitalizations for workup. And they really had tests to rule out every possible cardiac, pulmonary, and gastrointestinal disease. The patient did, in addition to the chest pain, the patient complained of some weakness and had some decreased reflexes. And so they, after doing all these other tests, they said, well, we should look at, possible neurologic causes. And that was what caused them to do the lumbar puncture as part of a big neurologic workup.
Got it. Thank you again.
Does that answer your question?
That does. Thank you.
Thank you. Our next question comes from the line of Derek Aquila of Wells Fargo. Your line is open, Derek.
Hi, this is Simona for Derek. Thank you for taking our questions. Just one from us today. So how should we think about the relevance of serum tryptase as a biomarker moving forward? And are you able to share the magnitude of tryptase reduction achieved and whether maximal mast cell depletion was maintained through week 12?
Sure, I'll take that question. So we believe serum tryptase has been a phenomenal biomarker to correlate with the clinical benefits of Barzol throughout the program, and has correlated very well with what we've seen in terms of tissue depletion of mast cells. So currently, this does not change our view on tryptase. While we haven't given the exact numbers, we certainly see profound depletion with the majority of patients getting below detectable levels, which are maintained throughout the treatment period. So very, very profound impact on serum tryptase levels, which we believe converts to very good depletion of tissue mast cells. As Anthony mentioned, we do have some biopsies from the lesions of these patients, and we hope to gain some greater insight what's happening in the tissues, and we'll certainly report that when we have those data.
Thank you. Do you have a timeline on when you'll have that data or any possible upcoming medical meetings?
No, we're still going through everything. As soon as we get it, we'll share it.
Thank you.
Thank you. Our next question comes from the line of Judah Frommer of Morgan Stanley. Your line is open, Judah.
Yeah, hi guys. Thanks for taking the question. I'm just curious if you have any updated thoughts. I know it's early, but just on drivers of the non-histaminergic itch here, I think beyond the well-validated cytokines from Dupi and Nemo, and then just specifically any thoughts on MRGPRX2 ligands and the role they might play given the update here. Thanks.
Where you want to take a shot at that?
Yeah, I don't think we have thought about this quite a bit. As Anthony mentioned, we received these data, which were surprising to us just a couple of days ago. We're still grappling with the differences between our phase 1b output and this study, which certainly raises questions about the role of mast cells in this indication. It's not something we've really thought about to address your question about what other mechanisms can be at play and what the role of X2-mediated activation of mast cells might be. So perhaps after we do additional analyses, we have.
So Judah, let us do the analyses on a bunch of stuff, and as we learn more, we'll be more than happy to share. We think this is important for the science going forward and for patients, and anything that we can learn and share, we'll do so.
Thanks.
Thank you. Our next question comes from the line of Alex Thompson of Stifel. Please go ahead, Alex.
Hi, this is Patrick on for Alex. One quick question on the phase 3 CSU top line. I guess what exactly will be included? Are we only expecting to get the week 12 primary outcome, or will we get that full 24-week data set?
You'll get 24-week randomized safety data with a 12-week primary endpoint. And again, it will be top line, and we will save the full data set for a medical meeting.
Thank you.
Got it.
Thank you. Our next question comes from the line of Andy Chen of Wolfe Research. Your line is open, Andy.
Hi, this is Jason taking it for Andy. I just wanted to ask about drug exposure compared between phase 1 and phase 2, since phase 1 was IV. So we just wanted to ask in terms of the dosage for SC in phase 2, did that change, or was there any thing accounted for when you guys went into dosages for phase 2?
People?
Well, certainly, sub-Q delivery is going to give different kinetics of exposure than intravenous administration. And while we get very good sustained exposure with our sub-Q regimens, you don't get that rapid high concentration exposure. Whether or not this could have contributed to the differences between our outcomes in the phase 1b or phase 2 is unknown. It's not something we can rule out at this time. Perhaps we'll learn a little bit more from the biopsy samples. But overall, as I mentioned before, we had very good tryptase reductions. We believe we have very strong mast cell depletion in the tissues, and our conclusion currently is that mast cells are not a driver in this disease based on the data we have.
I see. Thank you.
Thank you.
Our next question comes from the line of Richard Law of Goldman Sachs. Your line is open, Richard.
Hi, everyone. This is Tawani Usman for Rich. Thanks for taking our questions. Could you share any thoughts as to why, based on the encouraging phase 1 data that we saw and the alternative lack of effect that we saw in phase 2 results, could the formulation change from intravenous to sub-Q have had any effect, and could it have any read-through on ongoing trials by using the subcutaneous formulation?
You were coming in and out. I'm sorry to make you repeat the question. Can you repeat it?
Sorry about that. No problem at all. I was asking if you could share any thoughts as to why, based on the encouraging phase 1b data, with the IV formulation and then the alternative lack of effect to sub-Q, could that change in the formulation have had any effect, and could it have any read-through to other trials using the subcutaneous?
Sure. So the only change in formulation is really the concentration of the drug. So I don't think formulation per se was in effect. The route of administration, as we've discussed, is something that we're still trying to understand. There certainly is precedent for some treatments where intravenous induction is optimal for effect, and so whether that's a situation here or not, we don't know. But we believe that with our subcutaneous formulation, we are impacting the mast cells the way we expect to, and certainly has led to dramatic effects in our clinical outcomes in a number of other indications. So, we still have some work to do with the biopsy samples here to demonstrate that, but we're quite pleased with our sub-Q formulation.
Okay, got it. Thank you. And just one follow-up, if I may. Is there any read-through, in your view, from these studies, as well as EOE, PN, to CDX-622? And could that drug work when Barzo didn't use an indication?
So we're again still learning from these studies. If we don't believe that mast cells are a key driver, then it's definitely not a high priority indication. Where 622 is also working, at least through the mast cell depletion as part of its mechanism of action. So we'd be focused where there is clearly a role for mast cells, but that also includes other drivers in the case of 622, that being TSLP. If we are finding out with Barzol that mast cells are not playing a critical role, that diminishes the potential for 622 in those same indications.
Understood. Thank you.
Welcome.
Thank you. I would now like to turn the conference back to Anthony Marucci for closing remarks. Sir?
Thank you. And everyone, thank you for joining us tonight. We know this was short notice, and we appreciate all the time, the questions tonight. We look forward to coming back in a couple of months, September, October timeframe, to discuss our CSU readout. And in the meantime, if there are any questions moving forward, don't hesitate to give us a call. Have a great night.
This concludes today's conference call. Thank you for participating. You may now disconnect.